Hello, friends. Good evening. Yesterday, I could not complete the topic. That's why I have come up with the part two today. Yesterday, I almost finished the CPD and its assessment. Today, I'll be talking mostly on trial of labor. And when I had put up this, uh, many of my colleagues, HODs, professors, I had a good chat with them. They said, Murli, do you really think people in private practice nowadays give trial of labor? Well, I don't know what is the practice prevailing, but I personally feel if you do cesarean section for every single small borderline CPD, then you may land up with almost 70 to 80% cesarean section rate, which is not acceptable. At the same time, I do not want people to be obsessed with vaginal delivery if there is even a borderline or slightly more than borderline CPD, and then get into trouble both legally as well as it is not at all fair to give a dead baby or a complicated situation for the mother who has been waiting for 9 months. So we must have a balanced view. We must know about the CPD, and we must rule out the CPD before we decide to give vaginal delivery. And if there is any borderline CPD, there is a scope for trial of labor, whether you would like to adopt it or not. At least for postgraduates, it is important to know the pros and cons, how to select the cases, and what actually happens during trial of labor, where it should be given, and all the complications, etc. So that's the purpose of this particular talk. I hope it will be useful for the consultants as well. So this is what I was talking yesterday. Let me recapitulate quickly. In the Munroka-Muller's abdomino-vaginal method, which is the best method for assessing CPD, you have kept two fingers at the ischial spines and thumb on the symphysis pubis as depicted in the picture here, and the left hand is actually trying to push the baby inside. So the thumb is going to see whether the baby goes inside the pelvis very smoothly, or whether it touches or flushes with the thumb, or actually it lifts the thumb. And the two fingers at the ischial spine are waiting to see whether the presenting part in vertex, that is the vertex itself, can be palpated at the ischial spine, which automatically means the head is engaged. Right. So the interpretation, no CPD, means the head can be pushed easily into the brim without touching the thumb, plus the vertex is felt at ischial spine. In case of face presentation, the face has to be actually felt +2, not ischial spine, which I have explained yesterday already. Now, something like this, when you push, it goes very nicely inside up to the ischial spines. No CPD. What about gross CPD? Exactly opposite of that. Head cannot be pushed into the brim at all. And if you still push and push and push, it will override the symphysis pubis, lifting your thumb. So somewhat like this, you push it, as you can see here, it goes above the symphysis pubis. That's a gross CPD. And then we have a borderline CPD. Some books call it mild CPD, moderate CPD, or whatever it is. It is borderline CPD where head can be pushed slightly into the brim. The conical part of the head goes into the pelvic brim, but while doing so, as it comes somewhere here, it touches the thumb, just touches the thumb. But vertex will not go as low as ischial spine. Your fingers kept at ischial spine cannot feel the head. That means there's a borderline or a mild CPD. Okay. Now, you need to know the mathematics of it. See, obstetrics is almost like a mathematics. As I told you yesterday, the math between the BPD and the vertex is 5 centimeters, and the brim and the ischial spine is 5 centimeters. The BPD and face is 7 centimeters. Because of that mathematics, we could understand it easily. Here also, borderline CPD, is it just a subjective feeling? Yes, it is, but there is a mathematics also behind it, and that is the difference is hardly 5 millimeters. Yesterday, I was telling you the difference between a normal gynecoid pelvis and a contracted pelvis is 1 centimeter at all levels, at the brim, at the mid cavity, and at the outlet. Whereas when we say borderline CPD, it is not 1 centimeter, it is 5 millimeters. Now, this is very, very important. You will realize soon why I am harping on this 5 millimeter business. Okay. Now, it is somewhat like this, right? It is just trying to go inside, but it touches the fingers, thumb. That's borderless CPD. So, as I said yesterday, there is absolutely no doubt that CPD assessment has to be done, at least to me. And I also told Williams 25th edition also talks about it. But when to assess can be controversial, can be debated. I remember very well Dr. Matthew from Vellore long back. Once I used to have a discussion with him, and he said, we never assess CPD. We assess in the labor. If there is something wrong, then we will see. Because how can you assess the CPD when patient is not in labor was his argument. Yes, I partially agree with him. The argument is that the lower segment is not well formed, uterus is not contracting. How can you push the baby as low as ischial spines? Yes, there is a point to be noted. But the other argument can be, if you allow the baby or if you allow the mother to get deep into labor, and halfway through the labor, you realize that there is CPD, and then you will take her for emergency section. It is somewhat like giving worst of both worlds to her. So if you can assess with whatever limitations that it has before allowing her to vaginal delivery, I think you are doing a favor to the mother, to the baby, and to yourself. So that is exactly why I personally believe, and most of the textbooks still tell that CPD assessment can be done at term, that is around 37 plus weeks, maybe around 38, 39 weeks. Now the new term or the best time is 39 weeks, not 37 weeks. 37 weeks is only for cases like preeclampsia and other such complications, whereas normally 39 weeks is the best time, because after 39 weeks, the incidence of RDS is almost zero. So maybe you can assess at around 39 weeks when the lower segment is well formed, thinned out. You will be definitely able to push the baby as low as possible, even though the cervix is not effaced and dilated. At least you will get a good idea about the CPD, and it is in priming. Because in multigravida, we all know, even just before labor also, the head is high. Only at the start of the labor, maybe latent phase, it goes inside. And in multi, there is no need to assess in a way, because if there was CPD in the first pregnancy, obviously there will be CPD all the time. Once a CPD, always a CPD, because pelvis is not going to change. Babies are going to be bigger and bigger. However, suppose the previous pregnancy, the delivery was slightly earlier or preterm delivery, and there was no opportunity to assess the CPD, then definitely there is a case to assess CPD in the second gravida also. Shall I make it clear? Suppose in the first pregnancy, the delivery was preterm delivery, the baby was smaller, there was no actual assessment for CPD, then the gravida 2 almost becomes like a practical priming. Then yes, you have to assess the CPD in her also. I hope I'm very clear in that. Now in primary gravida, as I said, 38 to 40 weeks. I have just given a wide range, preferably after 39 weeks. And that's the time. In fact, you can do it as an outpatient itself when you do a PV, or maybe if you have planned induction after 39 weeks, just before that you can do. Again, I would prefer to rule out CPD and then only decide induction. Don't induce without, I will come to that again, whether induction is allowed in trial of labor or not. So better to always assess and then take a decision. I always tell, you have to take a decision. The job of a professor, job of a unit chief, job of a consultant is to take a decision. Cesarean section, anybody can do, even an SR does, even a senior most PG does. And delivery, even midwives do, and nurses can conduct delivery. But it is a decision that is very important, and that decision has to be taken whether to allow her for vaginal delivery or to do cesarean delivery. So it can be done in an early labor also. Suppose it is spontaneous labor, then only, not induced labor. Spontaneous labor, induced induction decision has to be taken only if there is no CPD. That is my opinion. In early labor, she comes to spontaneous labor, then of course the head would have engaged, or head would have gone inside the pelvis, not engaged, gone inside the pelvis in a primi gravida. Then also you can do a CPD assessment. Midway through the labor, I have put a question mark. This is the opinion of some of the obstetricians. They feel that you just allow her and let's see what happens. If the labor doesn't progress well, then you reassess and then you can find out a CPD. Of course, I don't subscribe to this thought. Multigravida, only in early labor. As I said, there's no point in doing at 38, 39 weeks, head will be high and mobile in multigravida. What are the problems with CPD? Why we must rule out CPD? Why I'm harping so much on that? Because antenatally, it will give rise to malpresentations. When the head cannot go inside, it will go to one of the sides. It is one of the causes of unstable lie at term. Unstable lie itself means when the lie keeps on changing after 37 weeks or 36, 37 weeks term. So it can go for a breech, transverse lie, and post dates. Unstable I already finished. Post dates. So CPD is one of the reasons why the pregnancy continues. So that is again unfair to allow the baby to go post date just because of CPD, right? Because post date is always dangerous. The time is ticking away, and Liker drastically comes down. That's because the placental reserve drastically comes down after 40 weeks. So, and in one of the papers published from Manipal itself, I think Dr. Prahlad published it, that Indian babies mature slightly faster. So that's why post-date is not good. Intranatally, early rupture of membranes can occur if there is CPD. That is one of the forerunners of CPD in case you have not assessed it. Cord prolapse can occur because if there is CPD and uterus contracts, membranes rupture early, and there is a space between the head and the pelvis, and cord can prolapse. So that's why I always say rule out CPD before allowing her for labor. Obstructed labor, you have not done CPD assessment, and you thought I would do midway in the labor, and you had left it to a junior partner or PG or somebody and who has not really understood the situation, and she will go for obstructed labor. And the next thing after obstructed labor is a rupture uterus, which will give rise to both feto-maternal morbidity as well as mortality. So what is the management? The management is very simple and straightforward. If there is no CPD, that is the case for vaginal delivery. I am not saying that should have vaginal delivery. That can be allowed for vaginal delivery if there is no CPD. Other reasons will decide whether to do section or not. If there is gross CPD, it is a no-brainer. You have to do not only cesarean section, elective cesarean section. I always insist on these adjectives. Usually PGs will answer cesarean section. No, you have to tell the word elective cesarean section. And in case of, when we give a VBAC, there you simply cannot say cesarean section. You have to say emergency cesarean section. So adjective is very important. Here it is elective cesarean section. Where it is borderline CPD, these are the cases which qualify for trial of labor. Well, whether you agree with me or not, especially in private practice, trial of labor should be given or not, I still firmly believe in giving trial of labor because we do give it in institutions. In Manipal, we have given lots of trial of labor and we have had successful trials in Manipal. Even VBAC also, though it has now becoming lesser and lesser because of the patient's choice, we have definitely given VBAC in Manipal. So trial of labor, the definition wise, you watch every word here. Trying for vaginal delivery. It is only trying for vaginal delivery. In cases of borderline CPD only. Of course, I don't have to tell in primi gravida. It is understood. Okay. under supervision. In probably private practice, you don't want to give trial of labor because you're the only doctor and you don't have a PG, you don't have an assistant professor, you don't have an associate professor to do the supervision maybe. And you cannot rely totally on the nurses. So every word is important here. Trying for vaginal delivery in cases of borderline CPD in primigravida under supervision. It is to be undertaken in tertiary care center only. So this automatically explains most of the private practices may be single nursing homes or single doctor nursing homes, and maybe at most secondary nursing home levels or hospital levels. So trial of labor has to be conducted in tertiary care center only. Okay, with all preparation for operative vaginal delivery, that is forceps or vacuum, and facility for cesarean section. I must add here NICU facilities and even ICU facilities, because sometimes suddenly things can change. You know, you are giving trial of labor, and sometimes the difference between rupture uterus and no rupture uterus can be hardly few minutes, and thereafter the baby can suddenly have problems. So you may need an NICU, you may need a ICU facility also. That's exactly why trial of labor should be conducted only in tertiary care center. I'm repeating it again and again. Now, this is a famous question. This is a very important question. They'll ask you in two different ways. What is the basis for giving trial of labor? When you know that there is borderline CPD, how dare you give trial of labor? That also one way of asking. Or what are the hopes of trial of labor? What is the magic that happens in labor? There are different ways of asking this. What is the magic you anticipate? What is your hope that she will have vaginal delivery? What is the basis for giving trial of labor? How dare you give trial of labor? Different ways of asking, but the answer is same. So really, magic happens. It is said that you don't get space from anywhere, but in labor, you get extra space from, I don't know where, heaven. You get extra space. How is that? With good uterine contraction, it helps in descent of the head down, and it nicely flexes the baby. So if it is a deflexed head, you have seen yesterday, occipitofrontal, 10.5 centimeters. When the head nicely flexes, it becomes suboccipitobregmatic, and that is 9.5 centimeters. So somewhere between 10.5, it can go up to 9.5. If it was 10, it can go again up to 9.5. So you will gain the sagittal diameter 5 to 10 millimeters. Now remember, what did I tell you? What is the difference between CPD and no CPD, borderline CPD and no CPD? 5 millimeters. CPD and no CPD is 1 centimeter. Borderline CPD and no CPD is 5 millimeters. So how much you have gained here now? Minimum 5 millimeters you have gained. This is the magic in the sagittal diameter. Now let us look at the transverse diameter. Now this is very important. The biparietal diameter is important. There is what is called physiologic molding of the fetal head. You know, in the fetus, the sutures are membranous and they are not ossified. So they are wide apart and they come closer. By coming closer, you gain up to 4 millimeters. How much? 4 millimeters. How much we needed? 5 millimeters. So we need 1 more millimeter. How do we gain 1 more millimeter? That's called give off the pelvis. The pelvis widens. Pelvis has got 3 joints. One is symphysis pubis in the front and 2 sacroiliac joints. All of these are cartilaginous joints and they are supple during pregnancy thanks to progesterone effect, and they widen. Not so much. I'm showing dramatically in the class, but you gain up to 5 millimeters. Now add 4 millimeters plus 5 millimeters. How much you gain? 9 millimeters. How much you wanted? 5 millimeters only. I insist on the word only. So you wanted only 5 millimeters for borderline CPD to become no CPD, and you have a chance to gain 9 millimeters in the transverse diameter. And in the sagittal diameter, 5 to 10 millimeters. If it was 10.5 centimeters, by good flexion, it becomes 9.5. If it was earlier 10, it also becomes 9.5. So 5 to 10 millimeters you gain in the sagittal diameter and up to 9 millimeters in the transverse diameter. So the net gain is something like 5 to 14 millimeters you can get. Sometimes it is more also. So I'm showing in a graphic. These are all, I love doing these graphics on the PPT. That is one of my hobbies and one of my pastimes. So as you can see here, let's say the occipitofrontal, this is the occiput and this is the frontal bone, was 10 centimeters, right? And by good flexion, it becomes 9.5, suboccipitopragmatic. So you gain 5 millimeters in the sagittal diameter. Now you just watch this biparietal diameter, how it shrinks. The molding, you gain 4 millimeters. It shrunk. Can you see that shrinking? So you gain 4 millimeters. Now you just see, give off the pelvis, to sacra ala, and this is the sacrum and to ala, they will separate. This was the symphysis pubis. This was sacroiliac joints. They widened. You gain 5 millimeters. You have gained 9 millimeters. Magic in labor. So you wanted 5 millimeters only. You got 9 millimeters in the transverse. You again wanted 5 millimeters. You can gain up to 10 millimeters in sagittal. So everywhere there is space, and this suddenly becomes borderline CPD to no CPD. Isn't it magic? Isn't it worth trying this? Under supervision, in tertiary care center, counseling the patient properly. Of course, there should not be any comorbidities. The question doesn't arise. And then you have taken consent for emergency section in case required. You have taken consent for forceps. You have taken consent for vacuum delivery. And you have taken consent for NICU admission, ICU admission, everything. Explain nicely to the patient. So you have saved one cesarean section. Contraindications for trial of labor. This should be understood very well. Just because I have explained beautifully and you have seen the magic happening, don't tomorrow onwards give trial of labor for everybody. You must know contraindications. Presence of any additional obstetric. When we say obstetric, there are typical obstetric problems. One of them is CPD itself. The second one is placenta previa, malpresentations. Of course, when we say malpresentation, it doesn't come under CPD because CPD itself means cephalopelvic disproportion. In breech, I told you it is fetopelvic disproportion. We don't discuss that at all. That is straight away for section anyway, by its own merit. So if there is an obstetric complication like placenta previa or medical complication like preeclampsia GDM, you have no right to give trial of labor. So it should be a pure case of borderline CPD. That means other than borderline CPD, there is no other problem. I'll repeat, other than borderline CPD, there is no other problem, either in the fetus or in the mother or obstetrically. That is the ideal case for giving trial of labor in a tertiary care center under supervision, under all facilities. And you are giving that because you know the borderline CPD can change into no CPD because of the changes that occur in labor. Namely, number one, physiological molding, wherein you gain 4 millimeters, give off the pelvis, where you gain 5 millimeters, and good uterine contraction, flexing of the head, you again gain 5 to 10 millimeters in the sagittal suture, sagittal diameter. So because of that, we are giving trial of labor. What is the role of induction? Now it's very easy to answer. I have told so much. The answer is no role for induction. I told you, you must rule out CPD before deciding on induction. You will do induction only if you are thinking of vaginal delivery. It's not like that we will chalo ye bhi dekhte hain, wo bhi dekhte hain. You cannot give worst of both worlds to the patient. Either you do elective cesarean section or you do induction because you have ruled out CPD, right? Of course, after induction, you may land up in cesarean section because of fetal distress. That's another matter. But you cannot induce if there is CPD. So there is no role. Because the mere fact that one has to induce labor means there is an additional problem. And what did I tell you in the previous slide? If there's an additional problem, either obstetric or medical, there is no role for giving trial of labor, obviously no role for induction as well. How do you manage the labor in a tertiary care center when you are giving trial of labor? Of course, you must have an honest PG. That's the minimum requirement. Or an honest intern. He should not only be honest, he should be dedicated, interested. He should keep his mobile switched off. And he should have coffee before, not in between. NPO for the mother, nil per oral. Why? Because you may land up in doing emergency section anytime. See, trial of labor does not mean you are guaranteeing vaginal delivery. No. The word says trying for vaginal delivery. Don't guarantee. Don't make it a prestige issue. Don't be obsessed with vaginal delivery. You should be prudent. You should be safe. You should be smart. You should not be dogmatic. You should not be egoistic. You should not be obsessed. Either way, vaginal delivery or abdominal delivery. You should be honest. IV fluids, because a cannula is always better so that you don't have to struggle in the last minute. Strict and close monitoring with partogram. Of course, partogram is now going to be changed to WHO labor care guide. I'm going to give a talk in Hyderabad next week. And after that, I'm going to give an online talk also. Till that, partogram is good enough. Look for normal progress of labor. That is cervical effacement, dilatation well applied to the head. Fetal heart rate is good. Head is descending properly. There is no cervical dystocia. There's no nothing. Progress of the descent and normal dilatation of cervix, that is well applied. Early rupture of membranes should not be there. That suggests CPD, I told you already. And no signs of obstructed labor, that is either Bandel's ring, or there should not be incoordinate uterine contraction in terms of constriction ring, not contraction ring, constriction ring. Nothing should be there. And no sense of fetal-maternal distress, no obstetrician distress, nothing. Okay, so these are very, very important things to be noted. I'll repeat, progressive descent of the head should be monitored. Normal effacement dilatation of cervix should be monitored. And not only that, cervix should be well applied to the head, which means head is going down nicely and putting 360-degree pressure on the cervix. No sense of obstructed labor in terms of Bandel's ring, and no fetal-maternal distress. What is the time limit? How long can we give trial of labor? This is a tricky question. Some students will say 4 hours, 6 hours, 8 hours, 12 hours. We are used to KBC, Amitabh Bachchan's. We need 4 options. And the examiner will give you 4 options. 4 hours, 6 hours, 8 hours, 10 hours. Don't fall into the trap. There is no time limit. What do you mean by that? Can I give indefinitely? No, that's not the meaning. The meaning is there is no specific time limit. Continue as long as. There comes the rider. As long as. Cervical dilatation is within limits of WHO labor care guide, does not cross alert line in the partogram. When it crosses, we need to reassess and take decision. Refer to my partogram class on the YouTube. There is no fetal-maternal distress. So as long as all these things are fine, that means cervix is dilating nicely, head is nicely applied to the cervix, descending nicely, no fetal distress, no maternal distress, no obstetrician distress, PG is smiling still, working hard, you can continue with the trial of labor. But if there is any problem, if the PG says I cannot monitor anymore, of course, you cannot do cesarean section because I've changed the PG, changed the intern. Active phase disorders and their diagnosis. Cervical dilatation disorders are divided into protracted active phase, means it's going very slow right from the beginning. You can see that 1 centimeter per hour in primary, 1.5 centimeters in multi, but it is going 1.5 or 2 centimeters even in, let's say, multi or in primary. Secondary arrest of dilatation. That means initially it was going fine, 1 centimeter per hour, but towards midway, it becomes very tardy and slow. Precipitate labor. Everything is fast within 3 hours. That's also bad. Then descent disorders. Protracted descent, something like protracted cervical dilatation, slow descent. That's obviously because of poor uterine contractions, and probably there is missed CPD. It is more than borderline. Arrest of descent. This is definitely gross CPD, which was missed. So if you plot it, it looks like this. Prolonged active phase, it looks like this. Dilatation plot crosses initially the alert line, and later action line if no intervention is taken. So right from the beginning, as you can see, right from the beginning, it is slow. Okay. Whereas secondary arrest is initially it was okay. It was on the alert line. Then it crosses something like late FGR or late onset FGR. What are the ominous signs? Incoordinate uterine contraction, constriction ring, Bandel ring, precipitate labor. All these are very bad signs. Bandel ring, constriction ring. Early rupture of membranes with cord prolapse. I told you early rupture means CPD. You have missed it. You thought it was borderline, but you have missed it. Progress crosses alert line, which you saw in the previous slide. Cervix is thick, edematous, and not well applied. Not well applied means head is not coming. Cervix has got two drivers. One is the uterine contraction itself. Other one is a 360-degree pressure of the head. So when the cervix is hanging loose, that means it is dilating only on the strength of uterine contraction, but not on the cervix, the head compressing on that. That means there is CPD. Severe caput and or pathological molding. See, you know the 4 grades. Just touching is proper physiological molding. Simple overlap which can be separated is grade 1. If it overlaps which cannot be separated, that is pathological molding. That is bad. Presence of fetal-maternal distress. You should monitor carefully for this. Trial may end in vaginal delivery with or without instruments, that is outlet forceps and vacuum assistance. Now, outlet forceps and vacuum are considered as acceptable in the normal labor. All of you know that. Or it may end in emergency cesarean section. So you have to have both the ends. But how do you interpret? What is successful trial? Successful trial is one that ends in vaginal delivery. But that's not all. Of a healthy baby without jeopardizing the maternal condition. So just because you have given a vaginal delivery, and if it's a dead baby, is it a successful trial? No, it's an utter failure, not only of the trial, of you and the whole institution. So vaginal delivery should happen without any problem to the baby or mother. Then only can you call it successful trial. What is failed trial? Now, in failed trial, the delivery is by cesarean section. Mother and baby are healthy, fine, but it is still called failed trial because the purpose of trial is to give vaginal delivery. Remember this. Here, mother and baby are fine, but you did a section. So it is a successful, finally, outcome. But as far as trial of labor is concerned, it is called failed trial. I hope I'm clear in this. Or, as I said, you may somehow hook or crook deliver vaginally, but it's a dead baby or a moribund baby. Or there are lots of maternal complications, including uterine rupture. No point. That is also called failed trial. So this is very, very important to understand. Successful trial is only when it is vaginal delivery with healthy baby and healthy mother. Whereas failed trial is cesarean section and or vaginal delivery with a dead baby or a maternal complication. So what are the questions are? Is there trial of labor in breach? No. No question. Can trying vaginal delivery in cases of previous LSS called trial of labor? No, ideally. It is better called VBAC. That's American terminology. But UK terminology is TOLAC. TOLAC means trial of labor after cesarean section. This is confusing because the word trial comes here. So ideally, trial of labor means trying for vaginal delivery in borderline CPD in a prime gravida only. Okay. Can we call it trial of scar? Maybe you can call it whatever you like. Contracted pelvis. This is the last slide. One or more diameter less than 10 centimeter, mainly at the brim or at any place. This I've told you yesterday itself. So let me repeat clearly. Gynecoid pelvis, all diameters are more than 10 centimeters, and it is almost round. Contracted pelvis means at all levels, the diameters are less than 10 centimeters or at least 1 centimeter less. Now, CPD means 1 centimeter less, mostly coinciding with contracted pelvis. Borderline CPD means 5 millimeters less. Assessment is always clinical. Thank you very much for your patient listening. I hope you enjoyed as much as I enjoyed taking these classes. Next class is on next Friday.